This video is an introductory video designed to give you a solid, systematic approach to chest x-rays. In part 2, we're going to practice applying this approach by looking at a few illustrative cases of common things that you're going to see and things that you shouldn't miss. The two most important things to take away from this first video are 1. Learning normal anatomy while really getting used to what normal looks like, and then 2. A solid approach to both frontal and lateral chest x-rays. There are a few things that we're going to cover first, but the anatomy and the approach are the main things that I want you to take away from this video. So let's get started. This is a chest x-ray. When most resources try to teach you an approach, the first thing that they tell you to do is to look at a bunch of quality things like patient name, date, a few technical things about film quality. I'm going to skip over most of this. A lot of basic chest x-ray resources give you a laundry list of things to think about when you're looking at chest x-rays, and to be honest, it can be a little bit overwhelming at first. So let's keep it simple and focus on the basics. With that being said, I'm going to mention a few technical things that I actually do think are important once you know the basic anatomy. Things like how you can tell if the patient is rotated. But again, for this video, don't get tied down with little details here and there. Focus on the basic principles and the big picture. As you know, chest x-rays use x-rays, a form of ionizing radiation. And it's probably important that you know about how much radiation that is and how to explain the radiation dose to patients. This bar graph shows typical effective radiation doses for different imaging studies in millisieverts. It's important to know that the background radiation dose that we are exposed to by just living on Earth from just background radiation, which is very low, is about 3 millisieverts per year. This helps us put these doses into perspective. A chest x-ray uses about 0.1 millisieverts of radiation, a very small amount. This is on the order of about 10 days of background radiation. A body CT, for comparison, is on the order of a few years of low-level background radiation, still a relatively low dose for a single exam. Don't get too bogged down with any of the numbers here. The key is that you know that yes, chest x-rays do use radiation, but the dose is very low and it's on the order of days of background radiation. There are a number of different chest x-ray views that you're commonly going to see, including PA, when the x-rays come from posterior to anterior through the body. APs, which are usually performed portably, is the opposite, so the x-rays are coming from anterior to posterior. These can either be done in a supine position with the patient lying flat or upright if the patient is sitting or standing. We also have lateral chest x-rays that we'll show you, and then other special views like a lateral decubitus views where the patient's on their side, and we'll talk about applications in the next video. The most common view that you're probably going to order and probably going to see for outpatients and relatively mobile patients in the emergency department is a PA view. And again, that means that the x-ray beams are going from the posterior side of the patient to the anterior side of the patient. The film is on the anterior aspect of the patient and is exposed by beams that make it through. Things that are closer to the film are going to look smaller, and anything further away from the film is going to look relatively magnified. So with that in mind, we can see why the orientation of the x-ray beams matter. Here we have two films. One is AP and the other is PA. The one on the left is the AP view, and the one on the right is the PA view. The film is usually labeled, but you can usually tell by just looking at the pictures. Things closer to the film are going to look smaller and sharper, and things further away from the film are going to look relatively magnified. On the PA view, you can see that the heart is smaller. You can see that the anterior ribs, which I've outlined here, are relatively sharper, and the overall quality of the film is better on the PA film here. As a result of all of these things, we're going to see more of the lungs on the PA film, and we're also going to be able to pick up more abnormalities. The PA and lateral films are the two standard chest x-rays that you're going to see most commonly in practice. For immobile patients, like patients in the ICU, who often get films daily, they are often taken portably by the patient's bed in AP. So back to our chest x-ray. We mentioned that x-ray beams that make it through the patient can be detected on the other side, and those that don't make it through obviously cannot. On an x-ray, areas that don't attenuate the x-rays as much, i.e. the x-rays that make it through easily, show up as darker. This means that, in general, less dense things look darker, like the lungs, and more dense things look brighter. We covered the basic radiographic densities in the Introduction to CT video and abdominal x-ray video, so we won't belabor the point, but it's important to remember the main radiographic densities. Remember, on CT we can quantify densities on a scale called the Hounsfield unit scale. This is also covered in our other videos like the Introduction to CT video in more detail. But for X-ray, things are a little bit more simple, so don't worry about this stuff for now. In general, we can simplify this to 4 principal radiographic densities. We have air that is very low density, we have bone and metal that are higher in density are going to show up as brighter, and then in between we have fat, water, and soft tissue. Remember, fat is less dense than water. If we mix oil and water, oil floats because it's less dense and it's going to show up as slightly darker than soft tissue and water. And if we look at a normal chest x-ray, we can immediately apply this basic knowledge. Although these structures are overlapping at any point on the image or on the x-ray is a reflection of all of the materials between the x-ray source and the film at that particular location, you can still identify the radiographic densities. The lungs are filled with air and show up as very dark. The bones are denser and show up relatively brighter. Soft tissues are slightly less dense. And there are even a few places on the x-ray where you just see fat and are relatively low density. So for example, you have subcutaneous fatty tissue that you see part of here that's darker than the soft tissues adjacent. You also see between the musculature planes of fatty tissue here that are relatively darker. And again, this is a normal chest x-ray. Another location where you commonly will see fat normally is up here in the neck. This is important to know because when you have pneumomediastinum or air in the mediastinum, it can track up into the neck, and gas in the neck soft tissues is often a sign for pneumomediastinum. For inexperienced readers, they might look at the fat here and wonder if it's gas. So remember what this normally looks like. Okay, now that you understand the basic densities, let's go through the normal anatomy. And we're going to go in order here. So number 1 here shows where the trachea is on a normal plain film. Number 2, the right mainstem bronchus. Number 3, the left mainstem bronchus. Number 4 is the left pulmonary artery. Number 5 is the right upper lobe pulmonary vein. Number 6 is the right interlobar artery. Number 7 is the right pulmonary vein. For number 4 to 7, it's not as important when you're starting out to be able to distinguish them individually. Instead, just get used to what the normal hyla look like, and we'll talk about that and show examples of it in a bit. Number 8 is the normal aortic arch. Number 9 is the SVC. Number 10 is where the azygos arches or azygos vein is. Number 11 is the right heart border, which is made of the right atrium. Remember, the right ventricle is an anterior structure. And number 12 is the left heart border, which is mainly the left ventricle and a little bit of left atrium. I'll also draw your attention to the space between the aorta here, or the aortic notch, and the pulmonary artery here. This here is called the AP window. For A for aorta, P for pulmonary artery. This should be concave. If this is convex or filled in, that's abnormal. This is a labeled lateral film, and we're going to go through the anatomy here and shortly go through an approach. Number 1 here is the trachea. Number 2 is bronchus intermedius. Number 3 is the left upper lobe bronchus. Number 4 is the right upper lobe bronchus. Number 5 is the left pulmonary artery. And number 6 is the right pulmonary artery. From 1 to 6, the only important things I think you need to know are you have a trachea here, you have lucent circles, which are the upper lobe bronchi on both sides, and then anteriorly you have a density, that is the right pulmonary artery, and posterior superiorly you have the left pulmonary artery density as well. Okay, so you're going to see a lucency down the middle, a density anteriorly, and a density posterior superiorly. You're going to have a relative paucity of densities in this inferior region here, and this is normal. If you have densities that are surrounding the entire bronchus here, that is often a sign of lymphadenopathy called the donut sign, so get used to this normal pattern at the hyla. Lucency down the middle, density anterior to it, that's the right pulmonary artery, and density posterior superiorly. 7 is the pulmonary vein confluence. 8 is the aortic arch. 9 is the SVC. 10, or the anterior heart border, is the border of the right ventricle. 11 and 12 are the posterior border of the heart here, made up of the 11 left atrium and 12 part of the left ventricle. I also want to point out a few other things about a normal lateral chest x-ray. This lucency posterior to the sternum here is called the retrosternal airspace. This should usually be relatively dark. This region here behind the heart is called the retrocardiac space. You'll notice that as you go down the spine, and the spinal elements are outlined here, the lung gets more and more lucent. This is called the spine sign. The lung should get more lucent as you go more inferiorly down the spine on the lateral. You have the costophrenic angles here, and this is where fluid's going to collect when you have small pleural effusions. Blunting of this is a sign of pleural effusion. The lateral chest x-rays are much more sensitive to smaller pleural effusions than the frontal chest x-rays. The right and left hemidiaphragms are marked off here as well. In telling which one's which, there are a few different ways you can do that. The one that I most commonly use is that the right hemidiaphragm you're going to see extend very clearly from posterior to anterior, where the left hemidiaphragm, you often lose it when it touches the heart. Also, the right hemidiaphragm is usually higher than the left, and this can be confirmed in the frontal. Okay, now that we've gone through the anatomy, we're going to go through a basic approach to chest x-ray. This is something that's going to be systematic and something that you're going to practice over and over and over again, and it's going to become second nature. So let's start with a frontal x-ray. So this is a PA film. I generally start by looking for lines and tubes and making sure that they're appropriately positioned. Things that you're commonly going to see include chest tubes, mediastinal drains, endotracheal tubes in the trachea, and central lines. We're going to talk about specific positioning of these tubes in another video. I then look at the heart. When I'm looking at the heart, I start by looking at the borders of the heart and the size of the heart. When I'm looking at the size, I'm looking for enlargement. Radiologists commonly use a cardiothoracic ratio on PA films, namely the ratio of the size of the heart in horizontal distance to the size of the entire chest here from pleura to pleura. The cardiothoracic ratio is normally less than 0.5 on a PA film. I then look at the position of the heart. This is a normal position, seeing if it's shifted one way or the other. I then look for anything that's very bright, namely calcifications or metal in the valves or in the pericardium, and then look for anything that's very dark, namely gas. So looking for gas around the heart in the setting of pneumopericardium. So to review, when I'm looking at the heart, I'm looking at borders, size, position, things that are very bright, and things that are very dark. When I look at the mediastinum, I'm doing the exact same thing. I'm looking at the borders. We see a normal AP window here. We see normal contours. The size, the position, looking for a shift of the mediastinum, anything that's very bright like calcifications, metal, foreign bodies, etc. Anything that's very dark, namely pneumomediastinum. When we have pneumomediastinum or pneumopericardium, what's the difference? Well, pneumo just means gas or air, and if it's pneumopericardium, it's gas in the pericardial sac that stays in the pericardial sac, and the reflection of the pericardium ends at the base of the great vessels. So you're only going to see gas below that level in pneumopericardium. In pneumomediastinum, you have gas throughout the mediastinum, which often dissects more superiorly in the mediastinum and then up into the neck commonly as well. As a general point, whenever you see air anywhere where it's not supposed to be, you need to figure out why it's there. I like to break this down simply by breaking it down into 3 categories. 1, air from outside the body, 2, air from inside the body, and 3, air from gas-forming infection. In this setting of pneumomediastinum, for example, air can come from outside the body, for example, if they had a recent surgery or open procedure, a line placement, or trauma. It can come from inside the patient, for example, from esophageal perforation, or it can come from a gas-forming infection, which is relatively rare. So remember, when you're trying to figure out why there is gas in an abnormal location, think, is it coming from outside the patient, somewhere inside the patient, or gas-forming infection? I then look at the lungs and I'm comparing both sides to look for asymmetry. Normally it's symmetric. And then I look at each lung more closely by zigzagging up the lungs for more subtle abnormalities. Again, remember that there's lung behind the diaphragm as well as behind the heart here as well. When I'm looking for abnormalities in the lung, the main things you're looking for include consolidation, which are going to look like fluffy, brighter opacities. Cloud-like opacities are other words that are used to describe consolidation. You're going to look for masses, which are more rounded abnormalities. And you're also going to look for abnormal reticulation. In other words, too many lines. In order to pick up a reticular abnormality, it's good to know what the normal vasculature looks like. I generally split the lungs into thirds. We have the medial third, the middle third, and the peripheral third. As you move out peripherally, you're going to have less and less markings, as you can see from normal vessels. In the peripheral third, you should have next to no or no markings in a normal situation. If you see too many lines here peripherally, that's abnormal. Once I've looked at the lungs, I look at the pleura. So I follow the pleura around in both lungs, mainly looking for pneumothoraces, aka gas in the pleural space, and pleural effusions. The most sensitive locations in an upright film are going to be the costophrenic angles. For a pleural effusion, you're going to see blunting of the costophrenic angle. Here it's very sharp. Remember, lateral films are more sensitive than frontal films for pleural effusions. And I'm also going to look in an upright patient for small pneumothoraces at the apex of the lung. You can also look for pleural calcifications. I then look at the abdomen, and you can watch the abdominal x-ray video for more details. The main thing you don't want to miss is free gas or free air under the diaphragm. In a patient who hasn't recently had surgery, this is often seen with bowel perforation, which is something you don't want to miss. I then look at the bones and soft tissues, starting with the spine, looking at each of the vertebral bodies. I look at the ribs, both the anterior ribs and the posterior ribs. I generally screen these quickly, screening the clavicles, the scapulae here, and any parts of the shoulders we can see, as well as the soft tissues, taking a quick look for any obvious gas or high density material. Once I've looked at all of these things, I have 4 checkpoints at places where people commonly miss things. The first is the apices. Small pneumothoraces and small masses are often missed here. 2 is the hyla. Get used to what these normal hyla look like. I look at the retrocardiac region again. Again, a common place for missed pathology. And then the retrodiaphragmatic regions of the lungs. As a brief aside, I did mention that I would briefly touch on a couple of quality things. First, to tell if the patient is rotated, I look at the medial aspects of the clavicles in comparison to the spinous processes here. The spinous processes should be more or less halfway between the medial aspect of the clavicles. In order to determine if the patient had a good enough inspiration, we generally want to see 6 anterior ribs or 10 posterior ribs projecting over the lungs. So here we have 1, 2, 3, 4, 5, 6 at least anterior ribs and several posterior ribs as well. So this is a good inspiration. Lastly, when someone says a film is overexposed, it means that too many x-rays got through and were detected on the film. So if a film is overexposed, it generally means that it looks too dark, and an underexposed film usually looks brighter. So it's the opposite of what we usually think with photography. To review this approach again, we have lines and tubes. We have the heart, remember, borders, size, position, things that are too bright, things that are too dark. Mediastinum, same thing, borders, size, position, things that are too bright, namely calcifications in metal, things that are too dark, namely looking for gas. Looking at the lungs, making sure to compare and not forget the blind spots. Looking at the pleura, looking at the upper abdomen, the bones and soft tissues, screening them, and then looking for our checkpoints. Again, the apices, the hyla, the retrocardiac region, and the retrodiaphragmatic region. This is a normal lateral film. There are a lot of different things that you can look at, and we talked about the anatomy, and I'll briefly orient you again. So this is the spine here. There's the trachea here that you can see very well. You see lucency, and you see the right pulmonary artery here that's lighter anteriorly, and the left pulmonary artery posterior superiorly. Remember, there's a relative paucity of density in this inferior region here. Get used to what that normal hyla looks like, because the lateral can be very helpful to determine if there is true adenopathy. Because beginners are usually a little bit worse at looking at the lateral films compared with the PA films, I'm going to give you a very simplified approach to the lateral chest x-ray. We're going to look at 5 main things, and then I'll mention a few others. But if you remember those 5 things, you're well ahead of the curve. Okay? I look at the retrosternal airspace, which should be lucent. Here it's brighter up at the top because the patient's arms are here. But in general, this should be lucent. And if it's not, it can indicate pathology such as, most commonly, an anterior mediastinal mass. I look at the retrocardiac area, which should be lucent here. I then look at the spine sign. So I'm looking at the spine itself, but also looking at the lungs overlying. So the lungs should get more and more lucent as you move more inferiorly. Oftentimes, if you have consolidation in either of the lower lobes, you're going to see that that does not happen, and there is something here that makes it look brighter. I then look at the hyla, and we talked about that anatomy again just now, looking for evidence of lymphadenopathy mainly. And then looking at the costophrenic angles, remember that the lateral film is more sensitive for pleural effusions than the frontal film. So again, a simplified lateral chest x-ray includes looking at the retrosternal airspace, the retrocardiac airspace, looking at the spine sign and the spine itself, looking at the hilar anatomy and making sure there's not lymphadenopathy, and looking at the costophrenic angles. Now that we've gone through the normal anatomy and you have a basic approach, you're getting to know what normal looks like. When you go through your approach, you're going to need to pick up things that are abnormal. This is going to come with practice. We're going to go through an example now, and the next video is exclusively dedicated to picking up those abnormalities. In my experience, when people first start reading x-rays, they're more often oversensitive at calling things that are normal abnormal. But the more you practice and the more you see, the better and more confident you're going to get. You're also going to get to know what the most common pathologies look like. So in the next video, we're going to apply our approach to several bread and butter cases and things that you shouldn't miss. Let's finish off this video by reading this chest x-ray. This is a 60-year-old smoker. So I'm going to start looking for lines and tubes. There's no lines or tubes. Looking at the heart. This is a portable film, but it's not enlarged. It's in normal position. The borders are okay. I don't see anything bright. I don't see any gas. The mediastinum, size, position, contours are okay. AP window is normal. There is calcification in the aorta, suggestive or in keeping with calcified atherosclerotic disease. And then look at the lungs, comparing both sides, and then zigzagging up each of the lungs, looking for more subtle abnormalities. I look at the pleura. There's no pleural effusion or pneumothoraces. There is some scarring at the apices here. No pneumothorax, no pleural effusion. Look at the abdomen. Nothing to comment on. Bones and soft tissues look okay. I then look at my checkpoints. So the apices, the hyla. These are normal hyla. The retrocardiac region, and the retrodiaphragmatic region. Okay, for those of you that were paying attention, you would pick up on this abnormality here. This ended up being a lung cancer, so it's obviously very important that it was picked up on this chest x-ray. Okay, so that's the end of this video. The main things I wanted you to take away are the basic anatomy, a basic approach to frontal and lateral chest x-rays, and really getting used to what normal looks like. The best way to get better at chest x-rays is to keep practicing and keep looking at cases. The next video, as I mentioned a couple times, is going to review several cases to help you practice your chest x-ray skills.